the cost of the medical scheme option, so it's more affordable for someone to actually join. There's no flexibility around that at this stage. There are regulations and policies that we're hoping comes in the near future that would enable the exemption from that prescribed minimum benefits. We are allowed to actually exclude some of those from the benefit offering.
Yeah. Because sorry, I'm interrupting you, but that's, I think, such an important point, is that often people are like, oh, medical aid is so expensive, without understanding that it's not because the medical aid is wanting to be expensive, but it's because the regulation is saying, well, PMBs have to, and that's prescribed minimum benefits, have to be included. So like the cheapest option still has to include these benefits. And that's why, I mean, like your entry-level medical aid options, you're talking over R1,000 each, just because of those PMBs.
No.
And that's something often I think people don't understand.
Yes. So yeah, unfortunately, in the environment we currently live in, that is the case. Like I said, there is hope for actually a shift in that, and opportunity for lower income earners to actually join a medical scheme.
Yeah.
We're hoping comes in the near future. But given that currently medical schemes could possibly be unaffordable to a large proportion of the market of South Africa.
Yeah.
That is where health insurance typically comes in.
Yes.
So health insurers, they do need an exemption from the Council for Medical Schemes to actually operate, because they don't provide the prescribed minimum benefits. There are only a number of providers that actually do provide health insurance. The market is quite, the providers in the market is quite limited.
Because exemptions aren't given easily, right? I mean, I don't even know if they're still given anymore.
Yeah, I don't think they actually allow new exemptions.
Yeah. So the market's not growing.
Yes.
Well, it's growing in that the number of providers. Yeah.
Yeah. But in that space, then those products are typically focused around preventative care and primary care. So it typically excludes any hospitalization, because that's the most expensive part of most expensive part of the medical scheme covered.
Yeah.
It typically does exclude that. So those people that are part of the health insurance would have to go to a state facility when they are admitted. But for the case of, for example, going to the GP, getting their chronic medicine, dentistry, that sort of thing, they're covered by this health insurance plan. So that's roughly the distinction between the two.
And the health insurance is obviously at a lower price point, yes, right? Which makes it more accessible, because it, as you said, doesn't have to have these PMBs. But the issue there obviously is that then if you do need to be hospitalized, there's no private care there. You'd have to go to a government facility, because that's not what that sort of product actually caters to. But it's kind of saying, well, something is better than nothing.
Yes.
Right? And maybe you could speak to, what is the sort of percentage of South Africans that sit in those different sectors that you've spoken about, like the medical scheme compared to sort of non-medical scheme?
So medical scheme, and I stand to be corrected, but there's about, I think it was about 9 million South Africans that belong to the medical scheme. So it's a very small proportion of South Africa.
So it's like maybe what, like 1 in 5, 1 in 6 South Africans are on a medical scheme. So it means that, I mean, the majority of South Africans are sitting outside of that space and are then either leveraging some form of health insurance, but majority of their healthcare would be in the government sector.
Majority of South African citizens are actually uncovered and would have to rely on the government sector to actually fund the healthcare.
Which is something that I think, given, well, as you said, like if regulation changes, there's massive sort of developments that could be made there.
No, definitely.
That's, I mean, that's quite exciting, actually. I don't know. It's like exciting for me. And
it's a very exciting environment to me.
Yeah,
healthcare changing.
Yeah, healthcare is incredible. And so one other thing I would like to say about the PMBs, what was the reasoning, do you think, for having these PMBs in every medical scheme option? Like, why do you think that was a call made by regulation, and why can't options just include whatever the medical scheme wants to include?
So I think the biggest reason for that is to some extent standardize the offering across the industry. In a life insurance space or a short-term insurance space, products are much more standardized because there's not a lot of flexibility in terms of like what you actually offer. If you want your car covered, you cover your car.
Yeah, I mean, with life insurance, like you die and then you get something.
So, and it's much easier for an individual to actually compare different options they have. I think that was a way of trying to standardize the offering across the medical schemes to at least to some extent have an idea of how one compares to another.
I think another thing that I always thought around that, even when I was writing my fellowship, is you also think about, like, we don't know the different ways that we can get sick, right? I think, like, death is in a way you understand it because you're like, okay, I die.
Yes.
But you can get sick in so many different ways. And I think the PMBs was a way of saying, okay, the data shows us the things that make people sick the most commonly. And we need to make sure that they're covered and they're cared for and that the product actually caters to that need to ensure that they actually are cared for and it doesn't default to the state, kind of thing, and yeah, an interesting thing to kind of think about from like a humanity perspective, I guess. But I think one thing you did say is you said, okay, the PMBs look to standardize, and yet we know that in the environment, there's so many things that make it difficult to look at options at different medical schemes across the board because, there's all these innovations that have come into the medical scheme space that sit on top of PMBs. So one of those innovations, which I think people sometimes don't understand, is the concept of a medical savings account. And can you speak to that? I mean, why does that exist even?
Yeah, so that typically caters for out-of-hospital expenditure. So when you're in a hospital, typically across all the plans on medical schemes, that is covered from this risk pool. So what I mean with this risk pool is any contributions that come in. So every individual belonging to the medical scheme pays a random amount. Part of their contribution goes into the risk pool, and we share that risk pool. So those that are very sick claim more, are hospitalized more, gets a larger chunk of that risk pool because the risk pool pays out for the in-hospital claims, whereas young and healthy people might not actually claim at all, so they get a smaller chunk of that risk pool. But it's,
But in time, I mean, they become the old people, right? So it's like it cycles kind of thing.
So it's very, very similar to almost like how a short-term insurance works for car insurance. You have insurance for the peace of mind. Some people have crashes and they use the benefits. Others doesn't have.
Yeah, with my driving, I'm joking.
So, and in other cases, you don't ever claim. So it's a similar concept in the medical scheme environment. On top of that is then the out-of-hospital benefits. Some plans or some of the hospital some of the benefits are actually still covered from this risk pool. So, for example, chronic conditions. If you're diagnosed with diabetes, your chronic meds, your GP consultations, etc., is also paid from this risk pool. But there are other benefits that are always at your discretion, and typically, and that's where the savings account has come in. Some plans do not offer a savings account, so they pay all the benefits, whether it's in hospital or out of hospital, from this risk pool. So in the case where you're a health member, you don't use anything, so you almost use it or lose it. It's within a year. So if whatever you've contributed in the year and you could claim from in the year, it pays out. But if you haven't used it that year, then that you've lost it, and it doesn't carry over to the next year. That's where the savings account comes in. So many medical scheme options now have a savings account. So that means when you pay a contribution to a medical scheme, a part of your contribution is paid to this risk pool to actually fund the hospital care and some of the chronic benefits, etc. But another part of it is actually paid into a savings account. So that savings account is yours. It's not pooled with any other funds. It's yours. It's like similar to a bank account. And you can decide what you want to use that savings for. So if you don't want to use it, it carries over to the next year. So it's not a use it or lose it type of thing. So if you're trying to build it up for some reason, you can build it up. If you're expecting a large claim or dental procedure.
Exactly. Cosmetic surgery.
But you can decide how you want to use it. If you want to see a specialist, it's paid from their savings account, and that money is yours. Whereas typically with the other version of the options where everything is paid from the risk benefit, so this risk pool, there are typically limits on what you can spend. Also there's a rand value cap on how much you can use for specialist visits, and if that is exhausted, then you have to pay out of pocket.
Okay.
So it just gives you a bit of flexibility in terms of deciding what you want to spend it on.
I think another thing that, often students ask me when I'm teaching the health sort of F100, they say, like, why would you have medical savings and you get to put money aside and, just use your own money then, and then you don't have to pay money into this medical scheme and have it sitting there. What would be your view of sort of the benefits of having that?
The benefit of having that is that you have the money available. Typically, if you don't, very few people actually set aside money have the discipline to set aside money for a rainy day when you need it.
100%.
The other benefit of it is that at the start, typically with majority of products or medical scheme plans, that whole savings account is unlocked on the 1st of January of the year. So say, for example, I contribute R1 every month to the savings account. So I would have contributed 12 Rand over the year. So I technically have a fund of 12 Rand available. That whole 12 Rand is unlocked in January.
Yeah.
So I can already use...
it's like an interest-free loan almost. Yeah, exactly.
So you can use it at the start of the year. You don't have to wait for the funds to actually build up to be able to pay for your health.
Which is really helpful because, I mean, when it comes to healthcare events, you never know when you're going to get sick, right? And so you may not, especially in January, because January feels like there's 7 months in 1 month, you may not have the funds in. And so having that medical savings can be really helpful, especially from like a family perspective, etc. Because now you have numerous different people who are getting sick at different times and whatever. So very, very interesting. I think one thing I'd also like us to maybe just define for the audience, what is the difference between the sort of primary, secondary, and tertiary? So you've spoken about primary sort of in the health insurance space. And then you have secondary, which is more hospital-based, and you've talked about it being more expensive. And then, but what is I mean, we talked about the difference, but we talked about the cost. So why is the cost so much more in a hospital setting, and what sort of drives that cost compared to primary?
Yeah, this level of services is just much larger than a primary sort of setup. A primary sort of setup, you typically have a consultation, maybe a test or two that goes with that, maybe medicine.
Yeah.
And in a hospital environment, typically you have to pay the hospital, you have to pay every single provider, the nursing staff.
I mean, you can pay for food, right?
Yeah. The nursing staff, I think, is typically covered within the hospital bill. But every provider, if you're going in for a surgery, you have to pay the anaesthetist, you have to pay the surgeon, you have to pay the surgeon for doing the rounds after the surgery, you have to pay the theatre. So there's a lot of different costs and it's actually quite expensive compared to a primary almost setting.
And I think something that we spoke about, I mentioned in another interview that I had, was that there's that element of cost and frequency, right? So in the primary care space, you have very high frequency because people will visit a GP, etc., quite frequently, but the cost is quite low. So effectively what you're saying is, I mean, we don't all go to hospital every year, but when we do go to hospital, it's infrequent, but it's very costly. And so from like an actuarial perspective, the drivers of that overall pricing or the costing is so different.
Very. And even within the hospital space, there are admissions that are very frequent, such as deliveries.
Yes.
And they are typically at a lower cost, but then there are very infrequent admissions that come at a very high cost.
Yeah.
For example, trauma sort of things.
Yeah. Also, when I priced the trauma products, it had no barely any data on it, because it is so infrequent. But when it did happen, it was like, what?
So I think that's also an important thing. Like, obviously, within the prescribed minimum benefits, there are benefits that need to be paid.
Yes.
But medical schemes have the flexibility of covering things over and above those prescribed minimum benefits
if they want
to. So I think that's also often something that is different across the different plans in the industry, because some on a hospital type of or for the hospital benefits only covers PMBs or covers PMBs and non-PMBs up to a limit.
Yeah.
And others cover have an unlimited cover for non-prescribed benefits.
Yeah.
Which is actually on face value for someone, an individual that doesn't work in the environment, that doesn't see the lines on two benefit brochures. You don't actually see that comparison and know what it means.
Yeah.
So it's very complex, and I think that's why advice and progress in this space is absolutely essential.
Agreed.
It's a very, very complex thing to actually understand and unpack and compare.
Yeah. I think one other thing I'd like us to talk about with regard to medical schemes is the concept of disease management. So we know that obviously risk management is something that is core to what actuaries do. Like, we identify risk, we try predict it, and we also try manage it, right? And disease management is something that is a type of risk management in the healthcare space. How does that sort of manifest in a medical scheme, and what are sort of the benefits of that?
So that's also very crucially important. Not only the disease management, but also trying to prevent the diseases from happening.
Yeah. So that's, what do you call that? Preventative.
Yes, preventative, and having people being aware of their health. I think we've seen it now in our data over the COVID period. People haven't done their screening. They haven't done their health checks. They haven't.
So they're not aware of where their health is sitting.
Which is a very important issue to address, because if people are aware of their risks, then we can actually prevent the disease from progressing. Whereas if they don't, then we typically pick up those cancers at a later stage or the diseases at a more complex stage. So
Yeah.
I think it's two parts to it. It's